Hello and welcome to Best of the Day from the 30th meeting of the Chemotherapy Foundation Symposium. This multi-day, multidisciplinary meeting was started 40 years ago by Dr. Ezra Greenspan, who passed away in 2004, and now this meeting is held every year in New York in memory of Dr. Greenspan and the great work he has done. So we will be having 4 sessions during this meeting talking about hematologic malignancies, GI malignancies, breast cancer, and lung cancer. And our first session during the Chemo Foundation Symposium is going to look at CLL, lymphoma, and multiple myeloma. And joining me for that session is Dr. Martin Coleman from the Weill College of Medicine at Cornell University. Mart, thanks so much for being with us and taking time out of your busy day.
Thank you for having me.
Well, I thought this morning's session was very nice, very interesting. Some review of a variety of upcoming agents in multiple myeloma and in CLL. But I thought one of the most interesting things, and one of the things that I just still don't feel completely comfortable with, is this whole concept of chimeric antigen receptor targeted T cells, and how these T cells are educated basically to attack CD19 bearing lymphoid cells. So tell us a little bit about this, about the work being done at Memorial Sloan Kettering and at Penn, and I guess also at UCSD by Tom Kipps.
Right. I think we have to understand what the antigen is. CD19, CD20, and CD22, you could call them, quotes, public antigens for lymphoma, except for the very youngest lymphocyte and the most mature lymphocyte, the plasma cell. We're talking about B cells now. Almost all of these cells have CD19, CD20, and CD22. Why they chose 19 over 20, I really don't know. But what they really do, in essence, is educate T cells to this antigen. And it's remarkable by how this particular new technique has been so successful in, at least preliminarily, taking patients who are almost virtually moribund with CLL and putting them into a complete remission. There is a problem, however. If you educate these lymphocytes, these T lymphocytes, to attack the CLL cell, because it has CD19 expressed, you're also teaching it to attack normal B cells that are CD19 expressed. As a result, you get B cell depletion, and all of these patients have become hypogammaglobulinemic and have required serial gamma globulin transfusions, or infusions, if you will, on a monthly basis. So
is the B cell depletion even greater than what's seen with anti-CD20 monoclonal antibodies?
It's very similar, except in essence, this technique seems to be even more potent. So you're really destroying these cells. And what happens is that if you try to recruit cells to mature, you've got these cells circulating to really, in a sense, knock them off as they form. So you ultimately become hypogamma. You become hypogamma also with Rituxan maintenance. Many of these patients become hypogammaglobulinemic, have an excess of infections. One of the things that I've encountered in using Rituxan, and I use a great deal of it, is that these patients will sometimes come down with chronic sinusitis, which will not clear regardless of the antibiotics, regardless of all the surgical techniques you want to employ. And they don't get better until you give them gamma globulin and give them antibiotics. So it's not just a free ride. There's no doubt that this is a very successful technique. It could certainly be applied to other lymphatic malignancies. It could be applied to lymphoma as easily as to chronic lymphatic leukemia. And I suspect you could educate these T cells to other antigens on other tumors. So it's an exciting new technique. And in many ways, it's a lot easier, frankly, than doing an allogeneic transplant. However, the key here is to find an antigen, let's say unique to CLL or not on very many cells, these educated T cells can attack. And my understanding is that Tom Kipps, he's presented some of these data, thinks he has found an antigen that isn't expressed on normal T cells. I presume that this is what we call a neoantigen, antigens that were expressed in the fetal condition, but as the body matures, these antigens go away. So he thinks he may have an antigen that is virtually tumor specific. Well, that would be exciting because now you can direct these T cells to attack just the tumor. And that's the whole rub with all of these vaccines, and that is to be able to come up with tumor-specific antigens. Usually the antigens on tumors are the same antigens as on normal cells, and that's what the problem is with this CD19.
So very exciting, definitely a double-edged sword at this point, but it will be fascinating to watch this technology evolve over the coming years.
To these people, they were surely going to die, so they don't, I'm sure, view it as a double-edged technique. Going in once a month for gamma globulin is a small price to pay. And by the way, this treatment is so very effective that you get really a huge rapid tumor lysis syndrome from the outset. And I think
cytokine release.
Cytokine release, absolutely. And at first, I think when they first started doing this, they were a little frightened, but apparently it's a sign that the system is working.
Right. Well, that's really interesting, and as I say, it'll be interesting to watch this technology as it grows and improves. So the other area in CLL, we've over the years developed combination regimens with purine analogs and alkylating agents and anti-CD20s, and now we have an alkylating purine analog combination in bendamustine. But this whole concept of B-cell receptor signaling that has been evolving over the past several years with the PI3 kinase inhibitors and the BTK inhibitors, and a number of years ago we heard about fostamatinib, the SYK inhibitors. So this was all updated today. Richard Furman from your organization talked about some of the studies that have been carried out and where these drugs are going in phase 3 and hopefully FDA approval and availability to everyone in the near future. Kind of update us, especially on the two drugs that have moved furthest along.
Well, the one drug, ibrutinib, is a very, very exciting drug, as is what we used to be called CAL-101. It's now PS1101. And they're fascinating. We'll call it CAL-101, although I think properly we should call it PS1101, is a PI3 kinase inhibitor. And ibrutinib, which used to be called PCI 32765, is Bruton's tyrosine kinase inhibitor. They are fabulous drugs. Dr. Furman at our institution at Cornell has really been a pathfinder in this area. And when you use these drugs, which are fairly simple to use with not that much toxicity, it's astounding to see what they can do. In chronic lymphatic leukemia, the nodes virtually shrink under your eyes. The nodes go down very, very rapidly, and there's this rush of lymphocytes into the periphery. Now,
this is a compartmental shift?
It's a huge shift. Now, what we think, and this actually has relevance to metronomic therapy to some degree, is that the CLL cell is nurtured by these nurse cells. And these nurse cells, the concept of nurse cells is probably different than stromal cells, but there's a close interrelationship with them. And there are certain chemokines that get released. There's one that's called CXCL12. There's another one that's called CXCL13. And it's a gradient sort of thing. And these chemokines attract the CLL cell to come close and to adhere to CXCR4, which is adhesion. That adhesion of the CLL cell to these nurse cells, if you would, gives it enormous viability. Now, if you look at where Bruton's tyrosine kinase is located, it's really downstream. Mm-hmm. So you're saying to yourself, it's downstream of the B-cell receptor. You're saying, well, this receptor up there, this tyrosine kinase receptor, is upstream. And so how does it impact it? How does it make it interfere with this to allow these cells to come out? Well, it's not that simple. And I suspect that ibrutinib does more than just interfere with Bruton's tyrosine kinase. What I think is happening is it's not a specific BTK inhibitor. And I think it has other impact. My understanding is that BTK inhibitors that are more specific for BTK don't work as well as ibrutinib. And what I think it does, it interferes with the signaling of stromal cells and or these nerve cells to entice, actually it's impacting these cells as well as a CLL
so
cell.
So it may have other unidentified
absolutely,
targets.
it allows these cells to flood out into the periphery. They ultimately die, so what you see is a surge of cells that gradually comes down. And since they're not that toxic, the thrust now is to take these two drugs and to put them in the clinic with drugs that we know that do knock down the count, whether this be rituximab, whether this be bendamustine and the such. Bendamustine is now the hot new alkylating agent, as you had mentioned, and it does have a purine chain. What role that purine chain plays, we really don't know. I've often wondered how much better bendamustine is than any other alkylating agent used to the same degree. Now, I think it is a very good drug, but I still maintain a little bit of healthy skepticism about its total utility. It was approved, of course, for CLL against chlorambucil, which is a weak opponent. And if you look at the original study by which bendamustine was approved, in point of fact is you had 3 times as much platelet toxicity and twice as much neutrophil toxicity as you had with the chlorambucil. So my argument was always, I went to the FDA one day to give them a lecture, my argument was, suppose you had pushed the chlorambucil harder, would you in fact have gotten the same results? Well, I don't really think so. I think there may be a little bit of magic to bendamustine. But I would like to point out to the audience that this is a potent drug and it is very marrow suppressive. We've generally been using it once a month, but I make it a rule that if the patient has not recovered their counts in that 1 month, I wait an extra week or even an extra 2 weeks so the counts get pretty close to its baseline levels. And the reason I say that is that if you really push this drug, you encounter a great deal of myelosuppression. I've spoken with Dr. Rummel, who did the original study in Germany, and he says he doesn't encounter it. But I do, and he's been using what is now the gold standard of 90 milligrams per meter on days 1 and 2. And there's now a study, a randomized study of BR, bendamustine Rituxan, versus FCR.
At the CLL-10.
Yes, and it'll be interesting to see what happens. But I'd like to see some other places, some other institutions, or some other countries doing these studies in a confirmatory manner. So far, most of the data have been generated from the various German study groups.
Right, and they have done a lot and completed large studies quickly.
And we're very envious, to be honest, here in the United States.
Absolutely.
I wonder if we could get our act together a little bit better.
What about lenalidomide? This is a drug that we have seen in CLL trials. Asher Khan has done some trials with lenalidomide, and Alessandro Ferrioli at MD Anderson. And there was initially some problems with tumor flare and tumor lysis, but they've begun at much lower doses, and it looks like that this drug has got some potential in CLL, especially perhaps when it's combined with rituximab.
That's quite correct. It's very interesting how the whole story evolved. As you know, in multiple myeloma, we use lenalidomide at a much higher dose, at 25 milligrams. And from my understanding is when they first started doing studies in CLL, they tried to use that same dosing, which was an unmitigated disaster. And they did encounter a great deal of tumor flare. My personal bias is I think tumor flare is, quotes, a good thing, because in my hands, at least, almost virtually all the patients who've had tumor flares have had excellent responses, telling you that there's something, this cytokine milieu, that it enhances the response. I don't see this when I employ lenalidomide or any of the IMiDs in myeloma. I have never encountered one. I understand from one person that they saw it in one patient, but it's extremely rare, and it's not rare. Now, what I have used for these flares has been steroids. Some people object to it because they think they're blunting some of the therapeutic effects, and in fact, in the CAR T, they worry about blunting some of the effects as well with steroids, but they still had to use them. But it hasn't seemed to make that much difference in my hands. I think Dr. Asher Khan prefers to use non-steroidals because he worries about the effect of the steroids. But nevertheless, we now start at much lower doses. You can, in one of our programs where we use what we call the thrill regimen, where we use alternating sequences, which I mentioned in today's lecture, of lenalidomide one day and thalidomide the next day, we've had very, very little flare. We've had a few, but very little flare problems, mainly because their doses are small. We're using 10 one day and 50 milligrams of thalidomide the next day. And we've had some remarkable responses. What we were trying to do is to cut down on the toxicity. Lenalidomide is basically a marotoxin. Thalidomide is basically a neurotoxin, but not much hematologic malignancy. So by using half the amount of drugs, we're able to actually give these drugs on a continuous basis. But yes, we use much lower doses of lenalidomide, 5, 10 milligrams in CLL. And it seems to be very, very effective and work very well. Most of the time we've used it in patients who have already been treated. But up front, it looks about as good as any drug that you have today.
Especially perhaps in the elderly, it may be well tolerated.
Well tolerated. Yeah. We kind of like our thrill regimen because we don't really encounter very much toxicity. And apparently, you know, they always say a rose by any other name is still a rose. One IMiD may not be exactly the same as another IMiD. And
that's for sure.
So we think that thal and lenalidomide may have a little bit different type of activity, and we've seen some lovely responses with virtually no toxicity.
Very good. Well, let me ask you, moving on to lymphoma, about your presentation this morning, and especially your Pepsi regimen and the evolution of that regimen as a metronomic form of therapy, because I've heard Hal Burstein talk about metronomic therapy in breast cancer, and we all remember the Cooper regimen, which gave multiple drugs either daily or weekly over prolonged periods of time. So what is the rationale for your metronomic Pepsi regimen, and where do you see that going?
Well, it's fascinating how this whole story started. And frankly, I think it was, we were a bit naive when we first started with the Pepsi regimen. Very often, Cornell is a tertiary care center, and very often we'll get patients who are really, in a sense, end stage or sort of beat up, if you will. And we wanted to have something that was very convenient. We didn't want to have them come in and get intravenous therapy. So we tried to come up with what we thought was combination chemotherapy, but in an oral regimen. So we put together this prednisone in the morning, the Cytoxan at lunchtime, all in small doses, 20 milligrams of prednisone, 50 milligrams of Cytoxan at lunchtime, 50 milligrams of etoposide, all oral medicine at dinner, and 50 milligrams of procarbazine at night. And we thought we were doing combination chemotherapy. So it turns out, if you look at the half-life of these oral drugs, there isn't a whole lot of combination chemotherapy going on here. And what you're really doing is giving just a low dose of chemotherapy on a continuous basis with drugs that have different efficacies. And we were astounded by some of the superb responses we had in heavily pretreated patients, heavily pretreated folliculars, mantle cells. The indolent lymphomas seem to do better. Mantle cell is not really truly an indolent lymphoma, but not the fastest growing lymphomas, did remarkably well with this. And even some of the aggressive lymphomas did very, very well. And we were very smug thinking we were giving combination chemotherapy. Well, one day at Cornell, Dr. Kerbel from Canada came down and gave the lecture on metronomic therapy because we have an angiogenesis center. And all of a sudden the bells went off, and we realized that this was probably metronomic therapy. And these are low doses of medicine, as you well know. But we do get hematologic toxicity, just like the Cooper regimen got hematologic toxicity. And I think the reason for it is that stem cells are rich in this MDR1 gene, this pump which pumps out the chemotherapy. But when you're giving continuous low dose therapy, you're pushing against that. The pump has to push against a gradient. And I think what you're overriding is this P-glycoprotein MDR1 gene pump that confers a certain amount of resistance to stem cells. You want to have this to protect you if you ever get exposed to a toxin. So we do get neutropenia, but then if we hold back and then we alter the number of days, but we always keep the drugs constant. So you use all 4 drugs maybe every other day, 5 out of 7 days, 1 week on, 1 week off. However it works out for the patient in terms of neutropenia.
Well, but these are heavily treated patients. They probably don't have the greatest marrow reserve to begin with.
That's correct. But we're getting responses in mantle cell and in folliculars that are all heavily pretreated in the 70 to 80% range with complete remissions up to 40%.
That's amazing.
Now what I'd like to point out is that when we have these mantle cell patients who've been heavily pretreated, we'll give them something like bortezomib, get a fraction of these responses that last for a short period, and everyone makes a big deal about it. We've also used, by the way, lenalidomide, which seems to work in mantle cell as well, but the results are short-lived. We've had patients up to 4.5 years on these medications. And very often we had the patients taken off because another new experimental drug came along that we wanted to try, i.e. ibrutinib,
Right. Well,
it's fascinating.
That is interesting. And so now you're adding an IMiD with that along with rituximab?
That's correct. And the reason we did that is there was a report from Austria that thalidomide with Revlimid was effective in mantle cell. And we thought that it made great sense to combine these two. Thalidomide didn't have much marrow toxicity, and neither did Rituxan, and we put them together. And we got again responses in mantle cell lymphoma at the 70% plus level. Now, how come we didn't do better with the second combo versus the first combo? Well, there was really a different group of patients, depending on how heavily pretreated they were, and we established much more rigid criteria for what constituted a complete remission. So did the thal and did the thalidomide and did the rituximab, did they add to the Pepsi? I'm not sure. We'd have to do a randomized study, but the problem is these are not new drugs right now that people would be very excited about testing.
Yeah, very good. Well, let's move on for the final portion and talk a little bit about multiple myeloma. Sundar Jagannath, who is now at Mount Sinai, having moved around New York a little bit in his career, talked about some of the novel agents that are still in investigational studies. Some have recently been approved, and some probably will be approved in the near future, but he covered the novel IMiD pomalidomide and some of the newer proteasome inhibitors. So what's going on in multiple myeloma as far as novel therapies is concerned?
I think the two that are one is on the market and one is probably imminent in terms of coming on the market. And that is carfilzomib is now on the market, and pomalidomide, I am certain, will receive FDA approval in the very, very near future. They're both excellent drugs. Pomalidomide is what we would now call a third-generation IMiD. We had the first generation of thalidomide, second generation lenalidomide, and the third generation of pomalidomide. And pomalidomide seems to work even in cases of where patients had failed lenalidomide. To be sure, the response rate is not that high, but it's clear that pomalidomide has some activity when the patient is resistant to lenalidomide or the tumor is resistant to lenalidomide. In similar fashion, carfilzomib also, which is now on the market, seems to work when bortezomib didn't seem to be working. Now, the response rates are not astounding, but nevertheless, the fact that they can respond tells us that these drugs are somewhat different in terms of how they're operating. Carfilzomib is an irreversible proteasome inhibitor, has very little neurotoxicity. There are some toxicities, but not really very major. And we don't even know what the highest dose of this drug is at this time. And they clearly work, and I think they probably work better. Now, as always, we always learn about drugs first in previously treated patients, usually heavily pretreated patients. But some of these drugs have been brought up front in an experimental fashion. And I'll just remark about two combinations which I think would be of interest. Carfilzomib has now been combined with lenalidomide. Dr. Jakubowicz at the University of Chicago did this and put the two drugs together and got some rather outstanding results. And what was fascinating about it is that the longer you kept the patient on therapy, the greater your chances for going into a complete remission and a strict complete remission. Virtually everyone responds. I mean, this is unheard of. Maybe 15 years ago in multiple myeloma, we never talked about complete remissions or strict complete remissions. That was just unheard of. And now we're getting these amazing responses. Now, what would really pique my interest is if one day up front we could take carfilzomib and combine it with pomalidomide. But that hasn't been done.
Right.
However, we at Cornell have put together a regimen, for better or for worse, which is called the CLAP regimen, which is clarithromycin, pomalidomide, and dexamethasone. And we think that clarithromycin adds to the effects of the IMiDs in combination with the steroids. This was something that came up a long time ago. We originally did it with thalidomide. We combined clarithromycin and steroids and got virtually almost 100% responses. We also combined it with lenalidomide and got outstanding responses.
Right.
And now we've combined it in pomalidomide, and we did it in patients who were enormously heavily pretreated. And the results have been rather astounding. Now, we take a lot of heat about clarithromycin and what does it do, and it has a fascinating origin. Many years ago, Dr. Dury claimed that clarithromycin worked in multiple myeloma, and we went back and tried it and were very unsuccessful. But what we did do is we had heard that it only works with steroids, so we added it to steroids in some end-stage patients and found out that we did get a drop in the response, in the protein spike. So we were getting some responses, and then when thalidomide came out, we just added it to it and got it was almost like Ollie's oil, as they say. The responses were remarkable. Some people say, well, how does it work? Well, we know that it alters steroid metabolism, but it also has other impacts as well, including on autophagy, and it also has other effects on the cytochrome system. So we think it's more than just altering the steroids. But what we at Cornell did with the Mayo Clinic is we did a head-to-head comparison. It was a retrospective head-to-head comparison of our clarithromycin with Dex and lenalidomide versus lenalidomide Dex, which Dr. Raj Kumar had done. And clearly, in almost every category, our results were superior to that without the clarithromycin.
Same doses of lenalidomide?
Same doses of lenalidomide, same doses of steroid.
Does clarithromycin add anything to the adverse event profile?
Yes, it does. It does give you more steroid toxicity. Okay. So one could argue that it gives you, that it's only an enhanced steroid effect. We don't really think so. We don't see that much in the terms of major complications as a result of adding clarithromycin in terms of the steroids, but clearly it does impact steroid metabolism, and that's been well proven in other diseases as well.
Right. And I think one of the more interesting agents that I discussed with Paul Richardson at ASCO is this MLN 9708, or what's called ixazomib now, and this is the first oral proteasome inhibitor that I understand is now moving further into the clinical trials in a phase 2 with lenalidomide. Have you had any experience with this agent?
I haven't used that agent, but my understanding is that it is actually as good as the parentally administered drugs. And that's kind of exciting because that will really make it so much easier to administer treatment to myeloma patients, and you can see where the natural sequence of events is going to go, and that is we will combine this drug, and it already has been with lenalidomide, to see how it works in combination.
All oral regimens.
All oral regimen, yeah. Harkening back to my Pepsi regimen in a sense.
Yeah.
But again, this is, to some degree, this may have an element of metronomic therapy because you're giving continuous low-dose therapy in contrast to pulse therapy or maximum tolerated therapy.
And I think Onyx also has an oral agent in their pipeline.
Obviously, competition works. The oral agent, I believe, for Onyx is, again, an irreversible proteasome inhibitor as opposed to the one by Millennium. That doesn't necessarily mean that it will be superior. It remains to be seen.
Remains to be seen. Well, Mort, thank you so much.
Thank you very much for having me.
This has been very interesting. It's really an enjoyable meeting. I came to this meeting multiple times when I was in practice in St. Louis and always found it very educational, very interesting. And it's great to sit down and talk to you about some of the presented data.
Well, thank you, and we'd like to invite you to our Lymphoma Myeloma 2013 conference, which I hope you'll enjoy equally as well.
Right, that is another great meeting, and I would encourage everyone to attend that meeting if they have any interest in hematologic malignancies. So there will be more from this year's Chemotherapy Foundation Symposium, so be sure to check back with us as these are uploaded onto the website. You can sit comfortably at home and watch all the details of the meeting. Thanks again.